네, 안녕하세요. 서울 뿌리깊은치과의 조용진 원장입니다.
Greetings, this is Dr. Cho Young-jin of Seoul Deep Rooted Dental Clinic. Today I want to talk about delivery of implant prosthesis. The process of delivering implant prosthesis has similarities and differences compared to natural teeth prosthesis fitting process. While the fundamental procedure remains similar, utilizing abutment and connecting it with a screw distinguishes it. Especially in screw-type prosthesis where there is no cementation process, direct connection is done via screw. Let's look at the general process. We examine the prosthesis made from the lab on the model. Then we connect the abutment through X-ray, verify its complete seating, adjust proximal contacts, find right occlusion, then either proceed to cementation or screw tightening depending on the type. The process varies slightly among cement screw and ER type. Depending on the type, some steps may be added or removed. Let's take a look at the overall process. When the prosthesis is delivered to the clinic, we align it with the abutment on the master cast to inspect the contact dimensions and tightness to ensure that they align with our intentions. And we also verify the fitness of the crown or bridge margins, prosthesis design emergence profile, and the surface compatibility between the abutment and suprastructure on the master cast. If there are discrepancies or gaps in the contact or occlusion on the master cast, it's almost certain they won't fit intraorally, so it's crucial to ensure everything is perfect at this stage. After verifying the prosthesis, you need to move on to seating it intraorally. In the case requiring a jig, particularly with the ER or screw types, an additional jig is needed besides the abutment. Verification needs to be done if the jig aligns well with the abutment and, if applicable, whether the wing fits the adjacent natural teeth. When abutments without measures to prevent rotation, such as non-hex or non-octa, are used, the role of the jig, such as transfer jig, becomes even more important. We need to make sure that there is no gap between abutment and jig on the model, and whether there is passive fit. On the master cast, if there's no major issues with abutment prosthesis or jig, the abutment is seated when the patient comes in. Non-hex abutment is utilized for cementation type or ER type. In that case, delivery jig is used to seat the abutment intraorally. The prosthesis needs to go on top, so we need to make sure whether there's issue with the insertion path. Also, inspection is done to check whether there is proper space for prosthetic material and proximal area. Inspection is done with the abutment in using delivery jig. Once the abutment is seated, as was on the model, we check whether there's passive fit between the jig and the abutment. After that, X-ray is taken to check whether the abutment has been seated properly on the implant. This inspection needs to be done. Periapical X-ray is taken to check whether there's gap in the junction between the abutment and implant. In the case of external type, we can easily identify whether there's gap. You need to check that if seating has not been done properly, you need to do it again to make sure there's no gap between the implant and abutment. And then we need to move on to the next step. Once verified in the case of cementation type, you're not going to unscrew it, so you need to use the torque device recommended by the manufacturer and seat it before moving on to the next stage. With the abutment on, except for screw type, for ER type or cementation type, the superstructure is cemented just like as cementing on the natural tooth. Proximal contact is checked, followed by margin adaptation and occlusal adjustment. Following the order, we proceed. If you look at the proximal contact, you can use floss silk or articulating paper or film, as well as oil-based pen, to adjust the tight areas. When you adjust using floss, we need to make sure that the floss has sufficient tightness to prevent tearing or ripping. When using oil-based pen or articulating paper, these tools are used to verify where it is tight. So around the area where the marking is gone, while maintaining the crown contour, these areas are adjusted. We use various tools, but we cannot find the right contact with one particular tool. So we need to continue to communicate with the patient whether the patient feels tightness or not. We need to utilize the various tools to find the right fitness together with the patient. In connecting a prosthesis, it is not only crucial to check the contact surface area and tightness between the prosthesis and the adjacent natural tooth, you also need to check the one that is next to the adjacent tooth or even the contralateral side of the dental arch. Similar contact level needs to be achieved. Even after you believe you achieve the right contact, it's essential to evaluate the tightness and position not just by using the floss to check the strength, but also you pull it upwards or sideways. By doing this, you'll be able to get an idea where the contact area is in terms of horizontal and vertical dimension and the size of it. When you deliver implant prosthesis, you not only need to think about the contact relation with a natural tooth, but you also need to consider the contact of the tooth that is 1 or 2 teeth away. In between number 3 or 4 or 4 or 5, we need to look at how the contact used to be and how it changes after prostheses are delivered. We not only need to focus on the contact in this area, but also consider this area and the contralateral side. Contact tightness between natural teeth and between natural teeth and implanted prosthesis needs to be compared, and it needs to be similar for the patient to feel comfort. Once you have found the right contact, we need to look at the internal fitness. Just like doing natural teeth prosthesis, you can use a fit checker spray on the inner surface and get the premature contact information and adjust the internal fit accordingly. Unlike treating natural teeth with implants, the focus is on adjusting the fit between abutment and suprastructure. In the case of natural teeth, you look at internal fitness, and if there is premature contact, you remove the inner surface of the prosthesis, but in the case of implanted prosthesis, the abutment is prepped instead. Once internal fit is checked, then you move on to occlusal adjustment. Before moving on to occlusal adjustment, before seating prosthesis, you need to check the natural dentition. You need to check the existing occlusion first. Before delivering implanted prosthesis, you need to thoroughly inspect the existing occlusion, and you need to make the occlusion similar to that. You can use articulating paper, acufilm, shim stock, or indicator wax to do this. Just like contact, you look at adjacent teeth or natural teeth on the contralateral side or fixed prosthesis there. You check various occlusal relations using different tools so that existing occlusion and the occlusion after implant prosthesis delivery are similar. We use Acufilm 2 most frequently. There is the red side and black side. The red side is great for registering occlusal contacts. When we use this, we not only look at the markings on the prosthesis or natural teeth. The marking is not 100% accurate. You check primarily using the markings, and then you use tweezer to pull it, and you feel the resistance. You use that for occlusal adjustments. After that, you can use a shim stock articulating paper, which is thinner, to check resistance. Tweezer can be used here. Once the occlusal adjustment has been done somewhat, you can use it on the implanted prosthesis, and you need to check the level of resistance there and compare it with the resistance you feel with adjacent teeth. The level of resistance needs to be similar. We also need to look at not just the markings on the teeth or prosthesis. When you use a shim stock articulating paper or Acufilm, you need to look at the level of resistance and whether there are any holes. Just by looking at the color, the articulating paper, it's difficult to determine whether the occlusion is right or wrong. Just because there are marks here and not here, you cannot depend on that entirely. It's very difficult to make that decision just relying on articulating paper markings 100%, so we need to look at occlusal indicator wax and patient perception. We also need to look at the tapping sound when the patient bites down using the posterior teeth. Also, you need to utilize the sense you get when you put your finger on the buccal side of the natural teeth or prosthesis. We need to look at all these factors to get an overall picture. We need to utilize all these information to make the right assessment. Then we'll be able to fabricate the prosthesis that has similar occlusal patterns as adjacent natural teeth. After occlusal adjustment, bonding and screw hole filling remains. The screw hole filling should be done following the manufacturer's instructions. And this should be done after tightening procedure. Gutta-percha temporary resin, cotton, Teflon tape, one seal can be used. And on top, light GI amalgam composite resin can be used. Two types of paste, as shown, are used to fill the screw hole. As for cementation type, you use temporary resin, Teflon tape, or one seal to fill the hole, and on top you use a more permanent material and then proceed with cementation process. In the case of ER type, you put the cotton material inside the screw hole, and using permanent cement, you cement it, and afterwards it's removed to remove excess cement. After it's adapted once again, final material, composite resin or one seal can be used to block it. If it is screw type, a cementation process is unnecessary, so you can connect the prosthesis using the screw hole, adjust contact and occlusion. After that, you can use one seal or composite resin to fill the screw hole. In the past, gutta-percha or Teflon tape used to be used frequently, but these days, people use one seal because this is very convenient and it has many advantages. I normally use one seal clinically as well. You leave about 2 millimeters of space so that you can fill resin, and you use appropriate length one seal to fill the hole, and on top you put the composite resin and block the screw hole. There are different one seal products available for TSSS and US, and they come in different diameters and colors. It is marked every 1 millimeter, so after you assess the depths with probe, you cut the relevant length minus 2 millimeters. It can be used very easily. Even if you have to remove it from the screw hole, compared with cotton, there's no foul odor or foreign debris, so you can use it very easily clinically. For the cementation type, once the screw hole is filled, the cementation process begins. In the case of cement type, we need to ensure that there's no excess cement. During the cement bonding process, we need to make sure that excess cement is removed. The amount of the cement used is very important as well. There can be many methods available to remove excess cement. In the case of type, cement is used. However, the permanent adhesive is used extraorally, and excess cement is removed before adapting it intraorally, so it's more favorable in terms of removing excess cement. During the cementation process, to protect the screw, cotton can be used. After that, the final cement can be used to complete the cementation process. I've talked about the importance of removing excess cement in cementation type. If you look at the different methodologies, to give you an example, you can just put the cement in the marginal area or on the occlusal contact surface so that there is no overflow of excess cement. When you use stock abutment, after applying cement, you can do try-in and abutment analog so that the excess cement can come out. After that, using the cement that's remaining, you can do intraoral adhesion. Then you'll be able to minimize excess cement. In most cases, when you use custom abutment or stock abutment, you can adjust the occlusal surface or margin. Milling is utilized here, but in that case, abutment analog cannot be used. This is a method introduced in literature. Inside the prosthesis, you can add Teflon tape and then use silicone or bite material and make abutment analog on the spot. After that, you add cement and put it on the abutment analog as said before and allow the excess cement to come out. With the remaining cement, you can use it for adhesion. This is another way to prevent residual cement. When using cement-type prosthesis, it is imperative to confirm the absence of residual cement through an X-ray. In this case, if you look at the implant on the left, there is severe bone loss and implant was failed. We cannot say for sure that the excess cement was the primary cause, but removing excess cement is very important. In such clinical situations and prosthesis deliveries, utilizing periapical X-rays to confirm the removal of residual cement, validate the fit of the prosthesis, and check whether the abutment has right connection. When doing these inspections, periapical X-rays can be particularly meaningful. Today, we briefly reviewed the delivery process of 3 types of implant prosthesis: screw type, cementation type, and type. While similar steps and processes are involved for natural teeth and implant restorations, like adjusting occlusion and cementation, specific procedures, like the mounting of the abutment and the necessity for periapical X-rays in certain cases, mark notable differences. As for screw-type prosthesis, the delivery process is somewhat different from that of natural teeth. It does not utilize the cement. The margin and fit are ensured by the screw. Therefore, you need to practice and train yourself as to how to deliver screw-type prosthesis. The process of connecting abutment is different from that of natural teeth, so you need to use X-ray and Check whether the fit is correct between implant and abutment. You need to check the connection.
굉장히 중요하다 이렇게 말씀드릴 수가 있겠습니다. 그리고
Also, I've emphasized over and over about the importance of removing excess cement, so we need to pay a lot of attention to this process. Today, we have looked at the overall process of implant prosthesis delivery. I hope to elaborate more on these 3 types of prosthesis delivery methods in the offline course. I look forward to your interest and participation. Thank you for your attention.